Welcome everyone to the ESRD National Coordinating Center Learning and Action Network meeting for the month of August. Today we're talking about reducing hospitalizations and emergency department utilization. My name is Sarah Eve Schaefer. I am on the contract and our host for today. I'm going to start with just some light housekeeping. We're several months into the series, so we shorten this up a little bit. We do have a recording of the call, which we will share out after the presentation with the ESRD networks. Everyone is muted. We usually have a fair number of folks on the call, so it's easier that way. And before we move forward, I would like everyone to try out chat. We will use that to present questions or comments to the facilitators today. So if you can, please toggle over to chat, click on everyone and enter a message here, maybe about the state that you're calling in from or what you're looking forward to hearing today, just to make sure that the chat feature is working and that we do. Thank you, Colette, for kicking us off there. We do get these materials out to the ESRD networks following this call, so please give us a few days and we'll get that out. Wonderful. Looks like we are in full gear. Everything is working and we have hellos from around the country coming in on chat. So today for the Learning and Action Network, you made the time to come here, so please, listen and share in the chat feature. We do like this to be interactive. Think about how you could use this information at your facility. Particularly, we ask you to think about one idea from today's meeting that you could implement at your facility, and then also commit to sharing what you've learned here today with colleagues that weren't on the call. So we also like to prime you with some questions to run on as we go through the presentations today. So let me plant these 3 questions in your mind. One of them is, what aha concepts might you hear today that you could introduce to leadership? How might your organization incorporate the ideas from the change package and the presentation to reduce hospitalizations? And how might my organization adapt new approaches to empowering patients to avoid avoidable hospitalizations? So we're going to make a plug here, just one short one for the NCC's change package. That's what a lot of this work comes from. You can see there's a QR code, so I'll pause. We'd like to get out your phone and at least pull up that PDF and email it to yourself or open it up. But this is a hospitalization change package. We are updating it. We will come out with a new one for 23, but this is last year's and it's full of great stuff. And without further ado, we're going to pause here and just see if anyone has used the ESRD National Coordinating Center's Hospitalization Change Package. If you can comment in the chat there, you familiar with this one? And if you're using it. Nope. Thank you, Jacqueline. Okay. Lots of no's and a couple of nopes. Great. Well, then we'll introduce you to some new information today and hopefully a great resource for the future. So we have 2 networks today. Networks with us are 1 and 2. And so we will move right into presentations with Jassy starting us off. Jassy.
Hi, everyone. So I'm very excited to be a part of today. So we utilize the hospitalization change packet, unbeknownst to us, actually. And some of the things that we noticed with reducing hospitalizations and readmissions and emergency department visits with our patients was our primary drivers were, I'm sorry. Can you go to the next slide? We're located in Lebanon, New Hampshire. We're open 6 days a week. We provide in-center dialysis, HHD, and PD, and we have an in-center census of 87 patients. Next slide. Our facility was asked to share a root cause analysis PDSA cycle, and we've used in the past and present to reduce hospitalizations, readmissions, and emergency visits. Next slide, please. So we took an integrated approach, and our facility took each primary driver from the NCC Hospitalization Change Package to work on our PDSA cycle. Our facility then took one secondary driver to focus on, identified one change idea from each, and tailored our interventions to our patient population. So our primary drivers were adopting a culture that embraces patient-centeredness and high performance. And the secondary driver with that was creating a culture that contributes to low hospitalization rates. Our other primary driver was implementing continuous quality improvement. And the secondary was tracking measures and discuss data in QAPI. Our next primary driver was implementing processes to prevent hospitalizations and avoid readmissions. And the secondary driver was to take a proactive approach to prevent hospitalizations. And our fourth primary driver was to educate patients and staff, with the secondary driver being preparing staff to prevent hospitalizations. We performed a root cause analysis in our clinic, and we discovered that patients' noncompliance with fluid management and mistreatments were causing the increased numbers of hospitalizations and emergency room visits. So for our PDSA cycle, we started off with handing out fluid report cards to our patients that showed what areas they were doing very well in and what areas they needed improvement in, ranging from their fluid intake to their blood pressure and treatment adherence. We reinforced education, we re-educated staff, and we really tried to promote makeup sessions for patients and adjust our schedule to the patient's needs. That was our planning stage. Our due stage was passing out the fluid report cards and reviewing them with patients. For reinforcing education, our PCTs were vital in this, and from our clinical services department, we reinforced tech talks, which were already determined by clinical services for our PCTs to review with the patients and talk to them about mistreatments, fluid management, etc. We then revised our schedule to allow a designated open chair for mistreatments or for extra sessions. And then we used a phone script for patients calling out of treatment. So instead of just saying, okay, we have a dedicated phone script to get the charge nurse and the social worker involved to reschedule treatments. For our study, we reviewed our clinical quality score and quality metrics monthly during our QAPI meetings. And for our ACT phase, we had a decrease in mistreatments in fluid action groups and correlated with the decrease in hospitalizations. Last year's facility goals and outcomes were a hospitalization goal 27 or less, and we ended the year with 14 hospitalizations. Our 30-day readmission goal was 4, and we ended the year with 0 readmissions. Emergency visit goal was 11, and we ended the year with 7 emergency room visits. Thank you so much.
Thank you, Jassy. Really like the tech talks. We're going to pause here. We only have 2 networks, so we have ample time. Let's pause here and see if there are any comments or questions for Jassy around her process or outcomes. You can pop those in chat, please. And I will share the QR code again at the close of the presentation if you need that. So we got a few questions here around the phone script. That seems to be a popular one. I know I like that one too. My ears perked up. Do you want to talk a little bit about the phone script, Jassy? Perhaps, what it was like and how you trained up staff to be able to share it and what the patient's reaction to it was?
Yes. So we started off with our monthly staff meetings and huddles, just trying to, remind our staff, please don't have the PCTs take the phone calls, or even if it's the nurses too, don't have them just take a patient calling out and say, okay, and get off the phone. We really wanted to have them redirect to the social worker and the charge nurse and myself. And staff get busy and keep forgetting to do this. So that's why it's more of a bullet point for our phone script where we just have the staff. It's posted at both nursing stations. And what we have with that is reminder, ask the patient if they can be placed on a brief hold and immediately transfer the call to the social worker, charge nurse, or myself, where we will reschedule the treatment for the next day. And typically, some of the things our patients have shared with us is they feel burdensome asking to make up a treatment because our patients see, everywhere they go, how short everywhere is. So instead of asking the patients, I would simply offer them the different appointment times we have available for that day so that they didn't feel burdensome in any way. And that's all listed in the bullet points of our phone script that we share with our techs and PCTs.
Great. Since we have the time, a few more questions came in. I think we're going to poke at that a little bit more. So did you have a designated chair? How were you able to predict which openings you might have to offer them?
So we had a TCU that we are no longer using due to staffing challenges, and we had 2 chairs in that area. So what we did is we blocked off those chairs completely as if they didn't really exist. They're made just for our patients that are in fluid overload, that need to come in for sequential treatments, patients that maybe had a GI upset the day of treatment and we were bringing in for the next day. So that no matter what, we'd be able to have these 2 chairs, and we could really, even though we're only open for the 2 shifts, we could utilize like 3 shifts of patients in there, especially if we have a sequential for only maybe a 2-hour treatment that day. So It took some planning, a little puzzle in the patient's schedule, but we were able to get those 2 chairs open for missed treatments.
That's great. That's great, especially right if it's a shorter treatment, you can kind of wedge it in there. And then a question too about the fluid report card. Was that something the facility came up with, or regional, or from your LDO?
So I can't share the fluid report card because it only comes populated with the patient information already on there, but it's kind of already, it comes from our EQ clinical reports. So we automatically get all of the patient information uploaded onto this paper that shows what they did well in and what they didn't do well in. But I had worked for a company previously that would just hand make these essentially with the dietitian and the social worker and the nurse together during IDT to kind of share with the patient what track they were on, what they were doing well, and what room there was for improvement.
Was the report card monthly? Did you give that with labs, or did you give it at a separate time or more frequently?
I usually gave it after labs, once we saw who was doing well, who wasn't, and could kind of see how we were doing over the past couple of weeks. So usually like midway through the month, we would pass them out.
Sure. And then just a question too about patient census. A few folks came through chat saying that, they experience high hospitalization rates, due to nursing home or SNF residents and the communication and those care coordination challenges we all face. Is that something that your facility has had experience with?
We have definitely had that experience here, but I think that was one of our really big barriers too, is when we went around and we talked to the patients doing our re-education, especially having our PCTs reinforce that education, because they spend the most time with the patients. So the patients really trust them, and the patients thought that they couldn't, come to us if they needed to reschedule. They assumed that they were kind of locked in where they were going to be, or they thought that if they weren't feeling well, they had to go to the hospital first, whereas we would tell them, unless it's obviously life-threatening symptoms, come to the nurses station to us and let our nurses evaluate you, especially if we have a doctor in the building. So yeah, we really just tried to open the lines of communication with our patients and let them know that we're here for them and that we can, we always can't move the schedule around.
Mm-hmm.
That's the reality of it, but we'll certainly 100% try our best to make it an option and help our patients wherever we can. Because life does happen, and it's very easy to miss an appointment or have something come up if they're not feeling well.
Sure, that's great. And I think your outcomes really showed that. And then we also had a question too about the tech talk. I really like that too, even the catchy name. So I think we all kind of understand that techs have the most face time with patients and really build that relationship. But how did you, keep the techs engaged and, really just keep them engaged to share this information and do it in a light kind of a light way?
Well, I think I had a little bit of luck on my side too, because my background, for almost 9 years was as a tech before I went into leadership. So I like to tell the techs, there has always been kind of a divide between the techs and the nurses. And a lot of times I feel that the techs don't realize just how valuable they are and how much time they spend with the patients, that they can really help influence positive patient outcomes. So I met with my team, I explained my background with them, and I tried to empower them and realize that they can affect our patients so much. They might not be able to provide the initial education, but they can reinforce them. Clinical services came out with the tech talks, just, highlighting the bullet points around phosphorus, mistreatments, fluid management, identifying, signs of anemia, things of that nature that have all been approved for the techs to discuss with a little handout for the patients. So it really was, we were very lucky with our staff. Our staff were really excited for the opportunity to do more. And I think people really rise to the occasion when you give them a chance.
That's great. Really appreciate that, Jassy. Lots of good nuggets in this. And I'll just ask one last question here for kind of, have you been able to keep these outcomes up? Do you have different strategies for sustaining this, or do you think that if you keep this process, the outcomes will remain as they were?
We've reached a little bit of a point of like a stalemate right now, where we're starting to notice a little bit of decline with patients wanting to go to the beach with the summer months. I thought that the winter would be more difficult, but I think it's the summer that's kind of been a little bit more difficult for us. So we are noticing a little bit of a decline. So we're really just trying to, now we're getting our dietitian involved, and we're actually getting our secretary involved too, so that everybody can really discuss, we can reschedule it. We don't want you to miss treatment just because it's the one beautiful day and 30 days of rain. Like, let us help you. So we're just trying to make it a team effort and get everybody involved. So we're hoping we're going to see more improvement next month.
Great. And a new PDSA cycle starts.
Yes.
Excellent, Jassy. Will you hang tight in case we have more questions at the end of the next presentation? But with that, I'm going to pass it over to Caroline.
Right. I'm Caroline Sander. I'm one of the assistant directors for the iPro ESRD network, and I'm going to be presenting on behalf of Network 2 today. Next slide, please. Just for some demographics, so Network 2 has approximately 31,000 patients, 356 dialysis centers, and then 13 transplant centers that we actively work with. Next slide. So for the hospitalization, readmission, and ED visit project area, these are a list of the most common barriers that we see in the Network 2 area. So in the New York area, so the overutilization of the emergency department, mistreatments, patients' lack of understanding of their discharge instructions, doctors routinely sending patients to the emergency department, and then also patient access to care. Next slide. So what we do with the community coalition, when we run a continuous community coalition, so we start a cycle, run those facilities through a set amount of time. Once they end, we either carry them through to another cycle or we select new facilities. But when we select these facilities for these community coalitions, we have reviewed data from every facility in our area, and we analyze it to see, are they, for their patient census, doing well in these goal areas? And could they benefit from working with us closer to solve some of their quality improvement, the barriers that they're seeing? And through this data analysis, we're able to identify top performing facilities. So facilities that are, they don't have a lot of hospitalizations, ER visits or 30-day readmissions, or some of those lower performing facilities who repeatedly have these occurrences. And then a new point that we add into our facility selection is we are looking at our priority zip code facilities. So facilities that are falling into zip codes that are known disparate areas, that is one of the selection criteria that we are looking at right now in the Network 2 area. We want to work with those facilities and really pinpoint their health equity barriers as well as their overall quality improvement barriers. Next slide, please. So since May, we've had this approach for our community coalition. We have decided to work with facilities through a root cause analysis and their Plan, Do, Study, Act cycle, but we also are conducting on-site visits. So a member of the ESRD network will actually come to the facility. And how that works with our community coalition cycles, we have the facilities identify their barrier. We say, hey, we're going to grab you to be a part of this group based on some of these criteria that we've seen. Maybe you have a high rate of hospitalizations. We have them identify their barrier, and they identify the barrier through root cause analysis. And then in between the root cause analysis and when they report on a plan to overcome that barrier, we're starting to do on-site visits to give one-on-one support to these facilities. So we can check on items that they've chosen through their transplant or their hospitalization change packet. They choose their primary and secondary drivers in this phase. We can follow up and give them assistance on being more successful, or helping them along the way, giving them encouragement, and identifying some of those health equity disparities along the way. Through this approach, we also are continuing work equally between the high and the low performing facilities, taking facilities that are being successful and sharing their practices with the lower performing facilities to give them ideas and ways that they could improve their practices. And then we also went ahead, and our coalition groups through all the different topic areas are staggered, allowing on-site personnel to really attack the facility or visit the facility during their RCA plan phase of their project right at the beginning. So we make sure they start off on this quality improvement project cycle right at the beginning with all of the feedback they need so they can continue it successfully. Next slide, please. So why merge on-site visits with our community coalitions? It's a greater engagement between us as the network and the facilities we're working with through their root cause analysis and Plan, Do, Study, Act cycle. It allows us to identify health equity barriers that are causing that low performing metric. So we chose you because we see maybe your hospitalization rates are very high. We're able now to integrate some health equity solutions that might be causing some low performing outcomes. We have a built-in embedded follow-up capability. So if we're visiting a facility at the beginning, at the end of the Plan, Do, Study, Act cycle, our quality improvement department is still working with them to overcome. We can follow up to see if the on-site visit was successful, if it yielded any great results. It allows us to provide one-on-one assistance, face-to-face, and real time. We know that staff are, they have a lot of work for their typical day, typical week. Doing a project solely through the computer can be very challenging. It allows us to bring you in face-to-face, bring in your entire care team face-to-face, foster that support in order to make those quality improvement projects more beneficial to the facility. And then we're also able to do patient and patient facility representative interviews in order to merge that patient family engagement aspect into the hospitalization quality improvement work. Next slide. So what have we learned? We've been doing these on-site visit and community coalition merge approach now for a couple of months. So what have we learned in terms of barriers? There are staffing concerns. I don't think that's any new information for many of you on the call, but staffing concerns are a barrier that are coming up very frequently during our visits. Provider and staff engagement and quality improvement, and some of that does go back to staffing concerns because you might just have enough staff to do the patient care and not do the extra quality improvement work, and so some of that engagement is lacking. Health literacy on the patient's behalf. There are a lot of health literacy barriers that have been coming up. Some of the patients have been quoted as being vaxxed out. So not wanting to get the vaccinations that they need, not wanting to make some of those healthier living decisions has been increasing hospitalizations on the back end and ER visits. We do have low patient facility representative participation in the area. So A patient facility representative, just to give some background information, is one of those really high-speed patients. They want to be involved in quality at the facility. They also work with us at the network to improve quality improvement for the patient. They act as the patient voice. A lot of the time, there is low patient facility representative participation, and you can imagine that causing, maybe less favorable outcomes for quality improvement. And then also with that comes lower patient participation in QAPI, which is the quality improvement meetings that occur at the facility. So you don't have a lot of patient involvement. You don't have that full circle holistic work being done in quality improvement. Next slide, please. So what have we provided after seeing and hearing about these barriers? Some mitigation strategies. So we prompt that patient facility representative recruitment and engagement. We do this through our community coalitions. We have a community outreach specialist that is promoting and prompting this recruitment and engagement. We have been doing demonstrations of iProLearn. iProLearn is our online learning management system. And we've been showing facilities how to become engaged, how to find the resources to help them in their hospitalization project if we're not physically there. So a demonstration of our platform and how to find this information independently. On site, we have been doing RCA and PDSA assistance. So we're able to see the landscape of the clinic and really understand, a reported barrier that the facility has given us might not be what we see when we walk in the door. And we can work with them on what they've already identified or maybe steer them in a better path, to more success. We've given them ideas on how to have patients integrated into QAPI. One of the biggest things we've heard is, our QAPI meetings there's a HIPAA concern. Maybe the patient schedule is not supportive of coming to QAPI. We give them all of these different alternatives to incorporating the voice into QAPI without them physically being there in order to get around some of these other barriers. Whether it's, having a liaison come in place of the patient who's a staff member and discuss the points the patient has written down or communicated prior to the meeting. The patient can call in virtually. There was even ideas such as having a suggestion box at the front desk where patients can drop suggestions or their ideas or their feedback on quality improvement, and they're represented when they're not physically present at the meeting. We've given them resources. These resources have been used to make bulletin boards and been disseminated to patients on how to remain out of the hospital. And then we are currently working internally to develop a health literacy provider CE course that also will turn into a patient-facing lesson, if you will. Next slide. So what have we gained with this new practice, combining these two approaches together? So we've learned a lot of best practices, being able to go into the facilities of our coalition. We're able to generate best practices, and then in turn, those facilities could become high performers in the future and help another facility who might be not doing so well in the future. We're learning that facilities, what their struggles are and what they're facing on a day-to-day basis. We're able to visualize it and see it and come up with better quality improvement outcomes and advice. We're able to see that there are barriers that cannot be controlled by the facility staff, and so it gives us a deeper understanding of the work on how we can incorporate QI into the site. We were able to gain the patient's perspective of the facility and the goals set forth by the network. And then we also were able to see what resources are needed in the future, and then also what mechanism is best to deliver those resources. Next slide. That's all I had for today for Network 2. If there's any questions.
Thank you, Caroline. We did just have one come through. Appreciate the discussion around patient involvement in QAPI. So there's a question around recording QAPI and sharing. Is that something that any of your facilities have trialed, or any other points there around including patients in coffee?
Some of the volume cut out, but I think the question is asking, has a facility recorded the QAPI meeting and then shared that with the patients for feedback? I actually haven't heard about that. It does seem like a rather elaborate approach, but it doesn't seem not unmanageable, right? So the patient can be fully present as if they were in the room. I'm not sure if anyone else on the call has ever done that. I have not heard of that method being used, not saying it wouldn't work, but I'm not experienced with the recording of the QAPI meeting in that fashion.
Okay, thank you. We will pause here and see if there are any other comments or questions for our presenters today. Really great presentations, Caroline, Jassy. Thank you so much for sharing your time and your experience with us. Yes, we do. Another comment then about the HIPAA issues for QAPI. I know that comes up a lot. Be on the lookout. The NCC will be posting new resources on QAPI QAPI in the month of August. So at the end of the month, those will go up on our site. So there'll be some new resources there. Companion pieces, one for the patient, one for the professional, and of course addressing HIPAA, because that always seems to come up. And some of that can come around the clarification of really what we should be talking about in QAPI best we can. Another question here about the patient representative. Perhaps, Caroline, could you talk a little about the PFR in case folks aren't as familiar with that? And then do you have an orientation, or is there some way that you share information with the patient reps?
Yeah, so the first thought that came up when I read this comment, every network is a little bit different. So I want to make sure before I speak that this comment is for like the New York area or any of the other iPro networks, because we have many people from around the country on the call right now. And so if I give you our method, it might not match what the other networks are doing. I guess the best thing I can say is each ESRD network, depending on where you live, does have a protocol to getting patients engaged. And it does include them typically filling out an application of some sort or signing up through the network. And so if you go onto your ESRD network's website, you should be able to navigate to the patient facility representative, or they go by different names depending on where you're at, to get that patient squared away with a representative from the network. That's the best blanket statement I can give.
Great, appreciate that caveat too, Caroline. Right, we do have folks from across the country, and each network does cover a different service area and have slightly different implementation paths. I will move forward, please. We still have time, so if there is anything else, comments as I close the call, please, do drop those in chat. And I'm actually going to go backwards quickly to reshare the QR code for the hospitalization packet, and I'll leave that on as we close. So let's go back to chat, and why don't you pop in chat something that you heard today that you're going to take back to your facility, your organization, your leadership, yourself, and implement regarding how we might prevent avoidable hospitalization. So here's a QR code. Drop any commitments you might make in chat. Wonderful. Thank you, Kimberly. Fluid report cards, that seemed like a winner. And the Tech Talk idea, also a winner. Phone script, Tech Talks, Open Shares, Tech Talks. Okay. Wonderful. Thank you. Jassy, you're starting a movement here with Tech Talks. Wonderful. And the phone script too. Great. So I will close our slide. Just click through. So again, we thank you for joining our speakers today and the ESRD NCC. We do host LANs twice a month on different topics. So please, keep your ears open on email for future presentations. And so as we think about the presentations today, we want to make sure that we're moving from learning to action, right? Away from these things with actionable, implementable steps. And so please share best practices from this presentation with your colleagues. Consider using the hospital change package. A lot of you had said that you maybe were aware of it or weren't aware of it. Please, we do those every year. They're culled from top performers in the country, across the, rural, urban, home, in-center. We really try to represent the population well. And so please consider using the change package as you work through reducing hospitalizations and then empowering patients to be active participants in helping your facility. Let me pause to promote the ESRD NCC on our social media and websites. And then also, when I close the call, there will be a short survey. Please make sure you take that and have a great day. Again, the recording and slide deck will be shared with ESRD networks, which will then be shared with facilities. So thank you so much for attending today. We look forward to seeing you at a future LAN, and take good care.